Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, friends. Thanks for joining me for this week's episode of the Healing Pain Podcast. This week, we're discussing how to treat, manage, and reverse diabetes through a combination of nutrition, exercise, and lifestyle medicine interventions. Diabetes is one of the fastest growing chronic conditions affecting physical health, physical function, as well as mental health and mental well-being. In the United States, most Americans are either pre-diabetic or diabetic. According to the latest CDC data, in 2020, at least 38% of U.S. adults had prediabetes. Most of these conditions go undiagnosed or often missed, and many go on to develop full diabetes. Diabetes majorly increases the risk of cardiovascular disease. If you have diabetes, you're more than likely to have heart disease or stroke. It also affects muscle tissue and nerves, especially peripheral nerves in the feet and hands, causing painful diabetic neuropathy. And it can damage the brain and the central nervous system, causing early cognitive decline and increase the risk for conditions such as Alzheimer's and dementia. My guest today is Dr. Rupal Patel. Dr. Patel is at the forefront of diabetes research and management, approaching it from a comprehensive, integrative, and lifestyle approach. Her PhD studies and dissertation work culminated in a randomized controlled trial of the effectiveness of a group-based, culturally tailored lifestyle intervention program on changes in risk factors for type 2 diabetes. On today's episode, we discuss how Dr. Patel created and tested a 12-week community-based group diabetes management program, which uses nutrition, exercise, and other lifestyle interventions. The participants of her group maintained positive lifestyle and biomarker changes past the 6-month period, which demonstrates that her intervention was useful for a long-term management of not only glucose regulation, but also diabetes care and prevention. Diabetes is a condition that impacts physical therapy care and rehabilitation across all physical therapy specialties, as well as subspecialties. On today's episode, we discuss the risk factors for diabetes, why lifestyle medicine is the first defense even before medication for the treatment of prediabetes, how to screen and intervene for diabetes in your clinic, free online resources you can use in your practice for diabetes education. And we also discuss the chapter that Dr. Patel wrote in the upcoming book, Integrative and Lifestyle Medicine in Physical Therapy. This text is now available for purchase. You can find it on Amazon or by going directly to the publisher's website at optp.com. This evidence-based text shows physical therapists how to use a biopsychosocial, systems-based integrative approach to physical therapy practice. As I mentioned before, Dr. Patel contributed to the section on diabetes care. If you listen to this episode and then purchase the textbook and read her section on diabetes, you will definitely be ahead of the curve in how to both manage, treat, and reverse diabetes. I had the opportunity to co-edit this textbook with my colleague and physical therapist, Dr. Ginger Gardner, and we're fortunate enough to have the contribution to over 40 other physical therapy researchers, educators, and clinicians that significantly contributed to this textbook. I'd like to personally thank everyone for their dedication and contribution to this great text, and especially thank our publisher, OPTP, for all of their editorial support. Okay, without further ado, let's begin and let's meet Dr. Rupal Patel and learn about managing diabetes from an integrative and lifestyle medicine perspective. Hey there, Rupal. Welcome to the show. It's great to have you here this week to talk about diabetes.
Thank you for having me, Joe. I'm really excited to be here.
I'm going to point people right away at the top of this episode to the book, Integrative and Lifestyle Medicine in Physical Therapy, because you penned a whole big section of a chapter on the care of diabetes and prevention and how we can use integrative and lifestyle medicine interventions as physical therapists. Everyone can find that book at the OPTP website. That's optp.com. But today we're going to talk a lot about diabetes, which I'm excited about. And I have to say, I love the stance that you're taking on this topic, Rupal, because it fits well within PT scope of practice with regard to prevention,
yes,
health and wellness promotion, as well as treatment and disease management and primary care physical therapy, all important topics that we really are discussing now in our practice, in our field, in our profession as DPTs and as physiotherapists across the globe. How did you get started in diabetes? Because I know I know a little bit of your backstory, but when you first got started, this wasn't a topic that PTs were talking about.
No, it wasn't. And it was actually not even a topic that I was thinking about as a physical therapist, except kind of as a sidebar, because so many of patients that I saw had diabetes as a condition. But it wasn't until I started my PhD work in health promotion and wellness that as we started taking classes and looking at primary prevention, looking at what are the big things that contribute to mortality in our country, and heart disease and diabetes and obesity are, big factors. It kind of really made me think about looking upstream in terms of, as a physical therapist in clinical care, here I am, and I'm seeing people that already have diabetes, and sometimes by then it may be too late to do anything except more tertiary prevention or management. But if we can curtail this earlier, then we would improve our population's health. And that's kind of what we're about now as a profession, our vision being transforming society. And I feel like we can really transform society by, going more upstream and kind of thinking about prevention, primordial and primary prevention. And so that switch flipped in my brain really when I was doing my PhD work and the didactic classes I was taking. And diabetes particularly was of interest to me because my father-in-law had been a lifelong diabetic. And just around the time when I was starting my PhD, he moved to Dallas to be closer to us because he was getting pretty significantly ill, and he had to stop working at an early age, at the age of 62, before he was even eligible for Medicare. And here he is, an educated man, engineer, been in the United States, and he was an immigrant, but had been here for at least 25 plus years, and yet still, he had health insurance, all these things that we think of as factors that, are determinants of getting diabetes, but he didn't have that, those things that were barriers. So it really got me interested in like, what he's already getting sick, so we need to manage him and his diabetes, but what could have been done, And so I think just that personal connection, and then everything that I started learning about prevention, I kind of always reflected back on my father-in-law's experience and kind of thinking back like, oh, I wonder if he had this, could this have been different, and that kind of thing. So that's how I kind of got started in looking at it from just having a family member who had it, and seeing what he was going through, as well as just learning about the importance of prevention and how we can mitigate some of the mortality.
So the seed was planted early with you in your PhD program.
Yes, definitely. Which, again, in PT curricula, we don't tend to focus on it as much from a primary prevention. In my curriculum where I teach at Texas Women's University in Houston, we do have 2 courses on health promotion and wellness. And one of them has an individual health focus and one has a community health focus. So we do talk about prevention from that perspective, but I still feel like, it's an area that we could do better, in terms of education and also in practice, in terms of, having physical therapists kind of take on that more upstream approach and looking at it from a prevention lens with their patients and clients that are even, orthopedic clients that have sports issues, or young adults that have, potentially fatty liver disease that, are going to end up with diabetes if nothing gets done in terms of their nutrition and their weight and other things, So I think we have some work to do in that area.
Well said. So how deep did you go into your PhD with regard to this topic on diabetes?
Well, on diabetes, not particularly. I think, in the assignments that we did as part of different courses, we have the choice of kind of digging deeper into an area. And so I kind of focused in on that area, but we learned about things like, okay, primary prevention, what are different ways to do that? And then I took at it as, okay, how can I apply this now to a patient with diabetes or a patient with risk factors for diabetes, whether they be genetic or behavioral or lifestyle or environmental. And then when we talk about health behavior change and utilization of health coaching and motivational interviewing, okay, how can I apply that to a person with diabetes to help them with self-management, or someone who's pre-diabetic and help them with self-management and lifestyle medicine? So that's kind of the approach. We were given the different foundations of lifestyle medicine, and then we could apply it to, whatever patient population we chose, and diabetes was the population I chose.
And then you ran some kind of trial, I believe, on a diabetic population. Is that right?
Yeah, so that was my dissertation work. So at the end of our didactic coursework, as a PhD student, you do a dissertation. And so I chose to focus on community-based, lifestyle modification for people that were at risk for diabetes. And I chose the South Asian or Asian Indian population because one of the things that I found through research when I was going through my PhD is that the aggregation of data, meaning that putting everybody together in one grouping of Asian Americans, kind of dilutes the data, and it doesn't show the disparities in terms of diabetes as a diagnosis and heart disease within subpopulations, because Asians are very wide. You have Southeast Asians, South Asians, you have Chinese, Filipino, Vietnamese, Indian, Bangladeshi, and every ethnicity and every cohort is very different in their lifestyle and their practices, maybe religion, culture, acculturation in terms of how long they've been in America, and what type of lifestyle practices they have. And so the aggregate data was just diluting the population. And there were very few disaggregated articles out when I started. And so I chose to focus on the Asian Indians because they have the highest rates of heart disease next to Latinos in America, and so that was my focus for my RCT. And I decided that it was best to kind of go where the people are, because we know the determinants of health happen not in our clinical walls, but in places where we live and work and worship. And so I chose to partner with a Hindu temple and held my program at the temple before the services happened on Sundays, and so that I could run my 12-week program there. And I made sure that, the model I was using from the CDC and the National Diabetes Education Program that was designed for community-based, and the original program was Power to Prevent, which was for use in African American communities. I went into the Asian literature and kind of tailored each session to, cultural and linguistic practices of the Asian Indians that I was working with. And so it was and then we had a control arm of folks that, just got usual care, which was that, okay, eat right, exercise, and see you in 12 weeks, and then the weekly sessions were with the people that were in the intervention arm. And we went through the modules, which included nutrition. It included physical activity, stress. It included lots of different topics, and really kind of more of a group-based model. Is what it was. And so it was really powerful because we looked at outcomes, A1C being one, and that's kind of the gold standard in terms of do you make a difference. And we had significant changes, not just from pre to post, but also at 6 months. I went back and tested the folks again at 6 months in both the control and the intervention arm. And the intervention group retained the changes they had made in their A1C because of the lifestyle changes they learned to do gradually over time in that 12-week program. So that was really cool. And even now, years later, if I go to that temple for different festivals and services, I still see some of my participants from my trial, and they will still come and approach me and say, "Oh my gosh, we're still doing this, and we're still doing our exercise, or we're still using this cooking technique, or measuring this or doing that." So that's really heartening to see that, and then that they've gotten their friends and their family involved in also making lifestyle changes. So there's that snowball effect, which is always cool to see.
That's amazing. I mean, you're one of the few PTs that I know that have created and tested. I mean, I think the tested is the big part too, right? Created and tested a community-based intervention for people for diabetes management and prevention.
Yeah. And let me tell you, it wasn't easy. As a PT, I mean, I'll just be honest and say, when I was trying to do the dissertation work, of course you need funding, testing people for A1C, and you have to send the test samples to an independent lab that's certified and all that good stuff when you're doing it.
And just tell people what A1C is and why that's so important for that population and what that means.
Yeah, that would be good, right? So A1C is the acronym we use for looking at the blood glucose level on average over 3 months, and so typically for a diagnosis for prediabetes is 5.7% to 6.4%. So most Americans, kind of fall in that pre-diabetic range, and then diabetes is 6.4% and above. And so it's looking at your average blood sugar, over 2 to 3 months is what A1C detects in the blood. And it's a good measure because, if you do fasting blood glucose, that just tells you kind of your fast from the past 12 hours. And we could all kind of cheat and do really good and not carb load and, be really good the day or two before. And our fasting blood glucose would, be fairly normal. But you can't really cheat on A1C because that's your average, blood glucose over 2 to 3 months.
Right. So your fasting is a snapshot of what happened within the last, let's say, 12 to 24 hours, where your A1C is important because it gives you an average look at what, let's say, your blood sugar has been like over a 3-month period.
Yep.
Right. And oftentimes the A1C is looked upon as kind of the one that's more important. Like we really want to track that one because we're hoping that people make these lifestyle changes over the course of the long term of their health. And we should see that A1C decrease. And also, I think it's incredible for those that obviously understand research. Most research will go back and look at 3 months, but you've continued into 6 months and have shown positive improvements from the intervention.
Yeah. And I think, from a research perspective, there's a lot of trials that do pre-post. And I think, anyone who goes through any kind of a modification program or even a physical therapy intervention program, you're going to see changes pre and post. But where the rubber really meets the road is sustainability, right? And when we're talking about lifestyle intervention and lifestyle modification, sustainability to me is the key. Because if you as a clinician or a researcher are not kind of looking at that, then I'm not sure if what you're doing is effective in the long term. And so I think that was important. And the community-based programs that the diabetes prevention program offers, it's actually a year long. The CDC one that is Medicare approved, if you as a provider wanted to, have one in your clinic, it needs to be a year-long program. And so, the first 3 months is intense, whether it's weekly or bi-weekly in terms of education and sessions, and then taper it down, to once every 2 weeks, once a month, and make sure you have that follow-up. And then in terms of your A1C and some other markers, kind of making sure that you're also keeping track of that. So that long-term is really important, so that I was, I wanted to build that into my RCT. But again, funding for physical therapist researchers to do that is very limited, and a couple of of smaller funding agencies that were specifically PT related at the state level, and even nationally. When I put in my proposal to help me with fund that RCT, it was like, oh, great study, great design, all this great stuff. Not sure how this applies to PT, and I was like, seriously, but so it's great. Glad to see now, years later, that I think, with this book that you and Ginger are leading the effort on as editors, that we'll hopefully get this information out as kind of like, this is important, for the health of our population. And if we're going to be doctors of physical therapists that are going to be out there in our communities, with the vision of transforming society, we need to pay attention to lifestyle medicine, and diabetes is largely preventable, and we just need more providers, and physical therapists are in a perfect place because, we see our patients and clients over time. It's not a one and done visit for most of us in any setting, whether it's in acute care, whether it's in a skilled nursing facility, outpatient, in inpatient rehab. We see our patients, we develop those relationships, we develop the trust. And I think that, Therapeutic Alliance is huge when you're talking about lifestyle modification with your clients and patients. And so I feel like we're in the perfect place to do it. I think what we're missing is our own self-efficacy to be able to do it. And that's where, as an educator, I want to be able to empower my students to kind of have the skill sets to be able to have those conversations, and to, if they don't have programs within their own clinical environments, then to plug them into where in the community can your patient or client go for the help that they need.
Yeah, I love that. And you're probably, so I don't know how I've recorded almost 400 episodes now. And I've talked a lot about self-efficacy on this podcast. Most of the time we're talking about helping a patient access or improve their self-efficacy. And I've spoken about this probably on the podcast. I've definitely mentioned it in the inner circles of, when I'm hanging out with colleagues at conferences. And you're the first person who's mentioned on the podcast that as PTs, we have to work on our own, or what I consider our professional self-efficacy.
Yep. No, I think that's huge. And especially in this, I don't consider this as an emerging area anymore. When I was studying it early in
say that again like 100 times, because that's the challenge, is that people like, PTs, what do you mean they're treating diabetes? And I'm like, yes. First of all, like if we wiped away sleep and nutrition and, wipe away all that stuff, just exercise alone is effective to manage diabetes. Then when you add in all the other lifestyle components that you speak about in your chapter in the textbook, which are well within our scope of practice, we talk about them in the book, you're teaching them in your health and wellness promotion classes on an individual and from a community perspective. And you have an RCT to support that. You went in and counseled on all these lifestyle interventions and had positive outcomes. And people are like, I don't see how this fits into PT, and why should a PT do this? And I just think like, oh boy, let's go to the bar and have a drink and like talk about this for like 4 hours. And I'll tell you how this squarely fits into our scope and how it helps with population health, right?
Yeah, well, and I think part of it is, I talk about this with my own faculty, and I think over time we have come around to kind of thinking about introducing these concepts of lifestyle management, lifestyle, factors that just impact health in general early in the curriculum. And so that way we start with a big picture in terms of what is health, what is wellness, what is prevention, all those things early on. And what are the big killers, in terms of our people, our population, and heart disease, being the number one killer, and like start there. And then kind of we get into our siloed mode, as what I call it, of, okay, neuromuscular PT, musculoskeletal PT, integumentary, cardiopulmonary, all the different practice patterns. And if we start that after we kind of introduce them to the broad, what is health and health promotion and what makes us healthy, then I feel like they would have the self-efficacy. and then we teach them those skills. And so that's why, as an educator, I'm very passionate about increasing self-efficacy of my graduates so that when they get out there, they will have it, to some extent. The challenge still is they learn these tricks and tools in school. And I even have them go and do a full-on annual wellness visit with a Medicare age patient. As you know, physical therapists are not reimbursed for that right now, but we should be. And so I always tell my students, I'm training you for the future of physical therapy. And so I want you to find a grandma or grandpa or an uncle or an aunt who's Medicare age, and here's what CMS requires for an annual wellness visit, and I want you to go do it. And here's how you do it, and they work on it in groups, but they learn, oh my gosh, initially they're like, oh my God, what are we doing? Blah, blah, blah. And then they do it. And I have them write a reflection along with their report. And they're like, wow, I would have never really thought I could do this unless I was made to do it. And this was a great experience. So, building that. And then when they go in the clinic, though, they have clinical instructors that don't have that self-efficacy. And so then they're hesitant, like, oh if my CI is not doing it, I'm not sure if I should be, could be, can I, and so that's the conversations we have now is like, can you level up your CI and, share some of the information that you have with them to help them, improve their self-efficacy in that. And then together, if they're willing, can you try some of these things in terms of lifestyle medicine and whatnot with your patient client?
Well, it's very refreshing. I mean, this is one of the reasons why I invited you to write on this chapter and, of course, to speak on this podcast. When I remember reaching out to you a while back, and we wound up on a topic on nutrition. Mm-hmm. And to be honest with you, I speak to educators today who are like, what are you teaching? What is it? Can you teach us? Can we do this? And you and I probably spoke over 3 years ago, and you were like, I've been counseling and teaching PTs about nutrition for almost a decade now.
Yep.
Yeah. For you, it's like, this is second nature. This is what we're doing.
Yeah. And again, it wasn't always. I think, I credit it to, again, having a focus on my PhD in health promotion and wellness. And we had nutrition classes. We had health behavior change classes. We, learned about how nutrition is so important. And, as a physical therapist, if you only focus on the physical aspect and the movement aspect, you're really doing your patient client a disservice, because that's only half the equation. Energy in is just as important as energy out, right, to me, and the quality of the energy in, and the quality of the energy out, right? So we focus a lot on the quantity and the quality and the prescription and what the patient can do from an exercise movement perspective, but that's just one half. And one of the things I tell my students, because they have very low self-efficacy for nutrition, and that's why we have 4 hours of that in our curriculum, and plus assignments and stuff that they do. And that's one of the things that they struggle with, is that I don't know enough, and it's like, okay, well, here's what you need to know. Here's what's within our scope of practice. And then here's how you can utilize that. So, I didn't always have that lens, but I realized, and then especially with diabetes, oh my gosh, when I say it's a lifestyle disease, most of it is nutrition. Yeah. And so in the U.S. diabetes prevention trials that occurred in the mid 90s, they showed that, basically, yes, the people did 30 minutes of moderate intensity exercise, 5 days equaling 115 minutes total, but it was really change in their diet, that was a key factor. And if they changed their diet, that actually helped them lose weight. And it's that weight loss, 5 to 7% a body weight loss really has a huge impact in terms of your hemoglobin A1C and your blood glucose level, and kind of bringing those down or controlling those. And so, so much of it is nutrition. And so I think that it's definitely something we should be focusing on. And in my PhD program, it was a PhD RD, registered dietitian, who was teaching those nutrition courses. And she had a really good perspective. She always told us, because we were all from different disciplines, is that as a dietitian, she makes it a point to counsel her patients, not just on the diet, but also on physical activity and movement. because again, she sees the importance of that, right? So as physical therapists or other healthcare professionals, we should all be doing the same thing,
That's right.
that within our scope, what is within our scope, we should counsel on nutrition, and, and then certainly physical activity is within our scope. We should do it.
Right.
So
And
I'm big.
Yeah. And something like blood sugar, when we say like counseling on nutrition, so it affects blood sugar, you first think, oh, that applies to diabetes. But then we also know through the evidence, which is building rapidly, when you regulate blood sugar, it also helps with things like regulating hormones and modulating pain and improving mental well-being. So it's not just the diabetes piece. Obviously, we're not treating single conditions, we're treating the whole person, right?
Yeah.
So counseling on those things that, yes, you made the initial diagnosis, someone may come to you, let's say with diabetes, and you start counseling them on how nutrition impacts their blood sugar, but it winds up taking a holistic approach and helps that person with their overall physical and mental well-being. With that, kind of on that note, if we kind of bring this full circle, obviously PTs are seeing patients in their practice who are definitely pre-diabetic. As you mentioned before, most Americans, probably about 2/3 of Americans are at least pre-diabetic, and another third at least are diabetic. How can a PT begin to screen and intervene with regard to pre-diabetes or diabetes?
Yeah, well, I think a very quick, easy tool is just the questions. So the ADA, which is the American Diabetes Association, they have a diabetes risk tool, and on their website you can find it online, and it's literally 7 questions, and you can open up your own browser in the clinic, have your patient go through it right then and there on a computer or on your tablet, or if they have a smartphone, they can do it on there. So you can kind of see what are the risk factors for diabetes that your patient, whether they have diabetes or not, has. And if they score 5 or more on that ADA risk tool, then that's something that you need to probably refer them to a primary care physician and have them checked for pre-diabetes if they haven't had a A1C or blood test done recently, and see where they're at so that they can kind of get that baseline, because most of the pre-diabetes is undiagnosed in our country, because most of us, don't have that tested regularly. Unless we have those lifestyle factors. So I think that's a quick and easy tool, 7 questions that, basically ask people about their lifestyle, have their weight, is one of them, whether they have family history, whether they have gestational diabetes, whether they have hypertension, those are all things that increase risk for diabetes. So just doing a quick screen and documenting it, not just asking the questions on intake, because I think a lot of times we have intake forms in a lot of our settings where we have check boxes where we ask that, but we don't really do anything with it. Whereas a risk tool is one where there's a score and there's a cutoff, and you can say, aha, my patient scored more than 5, so they're at higher risk. And so here's what I need to do about it. Refer them to get tested. And then if the test comes back and they are pre-diabetic, their A1C is that 5.7 to 6.4% range, then lifestyle medicine is basically the most evidence-based thing you can do. That's the first line of defense, for pre-diabetes. And so then it's a matter of, okay, in your setting as a physical therapist, do you counsel them on nutrition and on physical activity, and how to titrate that up in terms of physical activity to get to that 150 minutes moderate intensity with whatever, function and activity limitations they have. And then on the nutrition side, they're not diabetic, so, they may not need a registered dietitian to give them a quote unquote diabetic diet, but they're pre-diabetic. So we can definitely, from lifestyle medicine perspective, counsel them on, eating more complex carbohydrates, eating more fruits and vegetables, eating more lean meats, those kind of things. And there's wonderful tools that I, teach my students to access through my plate, and even through the ADA, that they can use as in part of their general counseling. And then motivational interviewing and health coaching, is a huge aspect of that. Instead of just telling people what to do and thinking about all the things they're missing and they're not doing, making it more of an asset-based approach. And let's focus on what you are doing and what can you add to what you're doing versus like not doing. And so I think that's a key piece, because as physical therapists, we kind of have these white coats on, where we're the experts and we're going to tell people what to do. And so that was another big thing I learned as a physical therapist going through my PhD program, is how to literally take off your white coat and kind of look at the worldview the patient has sitting alongside them and helping them kind of navigate and modify their lifestyle based on what are the factors in their life that are contributing to their health, and what are the barriers, and how can I help them navigate those barriers and empower them, to navigate those barriers, not me doing it for them or to them, but them doing that for themselves. And so I think as PTs, those are big things we can do. And I think we do that for the physical activity piece. So it's just a matter of flipping our switch and say, okay, well, I need to do that for sleep and for nutrition, because that's just as important to the immune system and to their pre-diabetic state as the physical activity is.
You're a full-time professor
Mm-hmm.
in a DPT program. So you're in contact not only with your colleagues in the program, but also colleagues in other programs across the US and globally. How would you like to see your colleagues take the information that you've written in this chapter and use it to inform DPT education?
Yeah, I think that, one, it would be wonderful if they, use our textbook as part of, education. And I think you've amassed just a great group of clinicians as well as educators for, this particular book. And so I think, something that I'll definitely propose to my faculty to utilize the book in terms of their education and others. But I think, having a textbook level knowledge now in this field is important, because it kind of signals that we have arrived in terms of lifestyle medicine, in terms of population health management, that this is part of our scope of practice. This is not just an emerging thing, but like, here it is. This is what it is, and it needs to be in the forefront. So I hope that, people will get the book and incorporate it in DPT education, either as standalone courses or, they could have it threaded throughout. And so, that would be the biggest thing is, these are the things that really impact health of our society, and not just in the US, but everywhere. Heart disease is the number one killer in the world, and diabetes is kind of either occurs in tandem, or it, who knows what comes first, the heart disease or the diabetes, or the vice versa. The studies show both. So I think this is a great way, this textbook and the chapters within it are a great way for people to realize that there is a role for physical therapy, and that we could play a big role, in this, because we see our patients over time. And when you think about chronic pain patients, which I know is your area of expertise, they're kind of patients and clients for life, right? They come and go with us in physical therapy. So my goodness, when we talk about diabetes, heart disease prevention, what a perfect opportunity to start that conversation when they first come into your clinical realm, and then follow with them over time and be that, person for them in terms of helping them navigate through those changes. So, if they're in a pre-diabetic state or in a diabetic state, like, here's how that's going to affect your chronic pain, your musculoskeletal health, and here's some things that I can work with you on to help you reduce or minimize those factors. That's not going to only help you improve your pain and musculoskeletal health, but the big thing, this big disease process that we want to stop, because we know the outcome of that is not going to be good for, some of the other things that are going on with you.
Yeah. It's interesting because I do some adjunct work at DPT programs, And I've spoke to you before in your program, you have two health and wellness promotion courses. One is more on the individual, the other is on the community health. I love that because it gives people obviously like a more specific kind of under the microscope, how do I treat the patient? But then a more broad, okay, I can also stretch this out and weave it into community health like you did. And not every program has that. As you mentioned, sometimes it's weeds within the curricula in different parts and pieces.
Yeah, no, our when we designed our DPT curriculum, that was I was just finishing my PhD, and so I was like, oh, we got to have this, and so the faculty kind of threw me a bone and said, okay, as long as you're willing to teach it, you can have it, and so it's been great because again, and whether it's good or bad, it's towards the end of the curriculum, which we're still kind of thinking about that again as we kind of think about restructuring our curriculum. Do we want to put it in the second year and make it like a longer stream for the course? But what we do is basically we have community partners, different organizations that are mainly organizations that don't have a lot of resources, and we partner with them to kind of really do a community needs assessment. And we go in and I tell the students, we, again, take the white coat off, go in, do our needs assessment, and then listen to the people, and then go into the literature, look at the evidence of what's changeable based on what the people tell us, and then develop whatever program that has to do with health promotion, prevention is kind of our loose topic for that population. So, we've developed programs like increasing water hydration program for people with mild Alzheimer's or early memory loss at a community-based center for mild memory loss with a social model, because they weren't hydrating enough. We've done things like nutrition programs, lots of those for parents of kids that are in early Head Start programs or, in Head Start programs, because nutrition, the schools, the Head Start schools, they had to abide by federal guidelines and whatnot to get their funding for their schools. But hey, the kids eating 2 meals a day, great in school, but then the parents feeding them junk food is not healthy, right? And building sustainable behavior change. So we had to get to the parents to, in that. And same thing, we've done physical activity programming again with parents of children, because, the kids were not active. And during the school, they have their PE, but very limited. And so working with parents and like, how do you take your kids to the park and play? And we were working with a lot of Latino immigrant families in that organization. And so they took their kids to play, but then they sat on benches and, chatted while the kids played. But, how do you emulate physical activity? So a lot of that community-based stuff that none of those things we dreamed up on our own. We had to go into the population. We had to listen. We had to go in with open minds and then kind of think about what's changeable in terms of some of those risk factors and what's sustainable, and so, those are the kind of things, we've done movement and memory programs, again, for people with early memory loss, with Parkinson's clients that are in community-based exercise classes. We've worked with those folks, people with stroke, and like empowering them to do more things on their own, and some of the mental health issues and depression and, those kind of things. So, I think lifestyle, and when we talk about community health, is, going in there without preconceived notions of what you as the professional feel like they need is something you have to really leave at the door. And then it's a group-based thing. So you're not, working with people individually, you're working with the whole population, that whole community. And so just how you tackle that is going to be different than the one-on-one thing that you're used to doing in your clinic, and so they learn that skill is that, your outcomes are knowledge. Sometimes it's self-efficacy. Does the group now have the skills, knowledge, efficacy, social support is a huge aspect of community health. In my diabetes prevention trial, that was one of the factors, that I didn't actually study, but just as I was going through the intervention and I was leading the intervention in my trial, I noticed how powerful that was, and so that's something, that we do need to study more is in that community group-based models, having that social support, having a group going through it together makes a big difference, and especially when you're looking at lifestyle modification, because if you're trying to eat well or better, but the group you're with, whether it's your work or your family or friends, are not the folks that are supportive of that, not intentionally or unintentionally, but just the environment that's created, then you're not going to be as successful, right? So having a group to kind of go do that together with is, I think, important. One of the last sessions that we did as a wrap-up session for my lifestyle modification program was kind of like having everyone do a potluck. And so all throughout the 12 weeks, I had, done different ways they can modify traditional recipes and still make them taste good, but modify it. Or what can you, like a my plate, what does a South Asian my plate look like, and like making that my plate. And so, I had given them lots of different resources and recipe modifications. And I said, okay, and everybody was doing their own thing. So the last session, we had a potluck where everybody brought something that they had modified that was their favorite dish or family dish or whatnot, to make it more healthy with the parameters of, what we talked about. And that was so empowering. Like everybody was like, oh, I love this. Can I have that recipe? Oh, that's so great. And so just that social support was just really powerful, so I think community-based stuff is so important. And I'm all for us as researchers and as clinicians getting out of our white walls in a clinic and going to where the people are, where they are, and doing some of our programming and there and being immersed in our community so that they see that we are there to support and help them, rather than coming in and telling them what to do, which people are tired of that. Like communities are tired of that.
Well, we're very fortunate to have you in the PT profession, as really, I really do believe that you're leading this aspect of diabetes care in PT management, which is important. And few people can really straddle everything you've talked about today, which is the individual factors and then the more community-based factors that you just ended with here. So people are going to want to learn more about you, especially educators are going to want to learn about what are you doing in the program, how are you weaving this in, what are the courses that you're teaching, and how do you weave in diabetes? So how can people learn more about you and the work you're doing?
Oh, gosh. Well, they can always contact me by email. I'm on the Texas Women's University School of Physical Therapy website as one of the faculty, and my email address, I don't know if we'll put that in the show notes or if you want me to just say it out loud, but it's rpatel@tw.edu. And so that's probably the best way. The RCT that I did is published in the Journal of Diabetes Research, which is an open access journal. So you can just Google Journal of Diabetes Research and put my name in it, and you'll come up with my study there. And in terms of the community-based health promotion, there was a method model paper a long time ago that my colleague, Dr. Tapley, and I wrote in the process and the model we use to teach that, which is the Precede Proceed model for community health promotion program planning and delivery and evaluation. And so we wrote a method model paper in the Journal of PT Education on kind of use of that model. And I've presented on that quite a bit. And like every year we have students use that model with these community-based projects. And I usually have students, if they're willing to submit a poster or a platform of it. And every year they get accepted. So even at CSM, you'll see, my students that are presenting that work, on how to utilize a evidence-based model to do community health promotion programming, and it's doable. And what's been cool is some of our graduates that have gone through our curriculum, then they get out there and they want to do more community-based stuff. And so they have then developed their own programs. One of our graduates who's an adjunct now in our program, his wife has MS and contracted MS when they were in undergraduate school together. And so they have kind of a program now that they lead, called MS Fit, for people in our community that have MS, and they do strength training and that social support and, empowerment and even advocacy work, in terms of contacting legislatures and that kind of thing. So it's been cool to kind of see that. And we've had others, develop other programs, and we've partnered with our graduates then to kind of help us become partners and do more. So that's always cool.
So all the links that Rupal Patel mentioned will be in the show notes. You can find them on the Integrative Pain Science Institute. Of course, as Rupal Patel mentioned, you can go to her website at the university. You'll find information about her there. But I ask you to share this episode with your friends and family and colleagues who are interested in learning more about addressing disparities in diabetes through community-based lifestyle modification programs, because it's a big topic in integrative and lifestyle medicine, that we address the well-being of people with prediabetes and diabetes. So make sure to share this out on Facebook, LinkedIn, Twitter. If you're on Instagram, take a picture of this episode and tag me, and I'll make sure to tag you back. Again, I want to thank Dr. Patel for being here, and we'll see you next week.
All right. Well, thank you, Joe. This was a quick hour flew by. Thank you. You were a great host.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.